Welcome to Kellie's News You Can Use, a podcast dedicated to healthcare information. Welcome to Kellie's News You Can Use. The month of June is Men's Health Month, and heart disease is one of the leading causes of death for men in the U.S. So I've asked Dr. Paul Rondino, a board-certified cardiologist, to talk with me today. Dr. Rondino received his degree from the University of Miami. He's part of the Broward Health system, and he has over 35 years of experience. Thank you for joining us today, Dr. Rondino.
Thank you for the invite.
So we'll jump right into, I guess the first question we'll talk about is, what is cardiovascular disease?
Cardiovascular disease is a process of plaque buildup in the arteries over time. Now, there's various other forms of disease, rhythms, and valvular disease problems, but I think for the focus for today will be mainly plaque buildup over time, leading to symptoms and complaints that patients would come to you with as a cardiologist.
Okay, so can you identify cardiovascular disease, and what are some of the key symptoms?
All right, well, as far as identification is concerned, you look at risk factors for the patient. There's two big groups. Number one group is genetic predisposition, means your family gave it to you, you can't change that. And then the modifiable risk factors would be your cholesterol, your blood pressure, diabetes, and tobacco use. So those would be the things that we want to modify as physicians to reduce risk for development of disease and progression of disease. Now, as far as symptoms are concerned, early on when you develop cholesterol plaque in your body, there are really no symptoms or complaints because the plaque is minimal, but you still have disease. Over time, when that plaque becomes significant and limiting flow to the heart muscle, you then get symptoms, which would be fatigue, weakness, chest pain, shortness of breath, palpitations, and a whole other laundry list of symptoms. But the big ones would be the pains, the pressures, the heaviness, the shortness of breath. And then that's what patients present with, and that requires then a further evaluation and management.
Okay, so when you talk about the genetic disposition to heart disease, when should somebody like that start to have that conversation with their primary care physician before they have to see you?
Well, the more risk factors and the more family background, the sooner you want to get evaluated. So let's take, for example, I see 30 and 40-year-olds with coronary disease. That's because everyone in their family, brothers, sisters, and parents, had disease at a young age. So as far as family risk is concerned, if your parents or your siblings have disease at a young age, and we use up to 60 years old as age, that would predispose you to having disease. Doesn't mean you're going to have it, but it means you're at risk. We don't have any specific tests to pre-identify 20-year-olds for disease. So we focus on family genetics and the family tree. So that would be something that you want to discuss with your physician. Now, if you have family risk, then it means you have to modify your modifiable risk factors early on. Stop smoking, get your blood pressure controlled, get your cholesterol controlled, get your diabetes controlled to reduce your risk for development of disease in mid to late life.
Interesting. And I keep hearing that diabetes plays such a factor in so many diseases. If someone is diabetic, are they at a much higher risk for heart disease?
Yes, they are. Diabetics have the worst of the prognosis of cardiovascular disease. And not only cardiovascular, when we talk about coronary disease and atherosclerotic heart disease, don't forget there's cerebral vascular, which is stroke, carotid, and peripheral vascular disease, which is your arms and legs in terms of cholesterol buildup. The pipes don't the pipes don't differentiate between heart versus brain versus legs. So disease everywhere in the body. And diabetics will be the worst of the worst. That's why we want to target their blood pressures lower than other people and target their cholesterols lower than other people.
Okay. And what are some of the screening tools that you use for people regarding cardiovascular disease?
Well, you start off with the basics. Blood pressure management, making sure their blood pressure stays less than 130/80. If it's above that point, treat it. Looking at cholesterol profile, breaking cholesterol down into what we call the good, the bad, and the ugly. LDL, the lousy, HDL, the healthy, and triglycerides, the terrible. So you want to achieve certain target goals for reduction in cholesterol. Looking at tobacco cessation and looking at diabetic control, targeting hemoglobin A1C, which is a marker of your sugar levels, to less than 6.5. So those would be the things that we want to start off with for screening and aggressive risk factor management going forward. Now, after you've done that, you want to do other tests that are helpful for screening and identifying disease. So there's a test called a coronary calcium score, a simple CT scan to look for the presence of calcification in the coronaries. If you develop plaque and the plaque lasts for a period of time, it becomes calcified. And when the plaque becomes calcified, that means you have, on a CT scan, abnormal findings and you have disease. Take it one step further, we've actually go to the point where we do CT angiography, which is now becoming a way to look at coronary arteries without doing cardiac catheterization. So no longer having to put tubes up into your body, but actually seeing on a CT scan, 10, 15-minute procedure with an IV in the back of the hand, and now looking for disease that way. So you screen for risk, and then you go forward based on the risk factors and testing to identify and then to predict long-term prognosis.
Very interesting. I learned a lot right there. So the other thing that we keep hearing about is having a healthy lifestyle to help reduce the risks. What exactly is a healthy lifestyle?
Well, exercise, 30 to 40 minutes of exercise, at least 5 days a week. Reducing alcohol consumption. Diet, modifying your diet, getting rid of the saturated fats. And then you want to work on, like I said before, salt intake, which is involved with blood pressure. Glucose control, sugar control, which is involved with diabetes, getting your food down so that you lower your cholesterol, lower your fat intake to reduce cholesterol. I mean, the rule of thumb is if it tastes good, it's bad for you, right? So these are all the things you want to work on in terms of what you can modify yourself without intervention with medications. But then a lot of issues come up where patients will need medication because they can't do it on their own. Their genetic background is such that if they eat cardboard and water, their cholesterol is still going to be high. So you have to get on medication.
And then there's people that can eat red meat and drink and don't necessarily have cardiovascular. So there's just a lot of moving pieces is what I keep hearing. Is there's genetics, but there's lifestyle, but there's no guarantee, correct?
Correct. Now you can have very good, strong family genetics and never have a heart problem. You will have some plaque, but it won't be significant enough to limit flow to the heart, and you never have symptoms. So there are 85-year-olds walking around with minimal plaque in their arteries and doing well with no symptoms. There are 40-year-olds getting angioplasties, which is balloons and stents, and bypass surgery because of their strong family genetics. That's why diet is important. You've heard of the Mediterranean diet.
Mm-hmm.
Mediterranean diet, high in fruits and vegetables and low in saturated fats. So people who live in the Mediterranean regions tend to have less heart disease than those outside those regions just because of that diet alone.
Wow. So the other information that we keep hearing is that men have a higher risk of heart disease than women. Why is that? But also, are you seeing more women with heart disease now? And what are the factors in that?
Okay, well, I'm going to make one quick correction to what you just said, because it's not so much risk, it's prevalence of disease. So men will have more prevalence of disease early on in life because women have estrogens, which are protective to developing heart disease until you reach menopause. So Women have diabetes, men have diabetes, women have high blood pressure, men have, so it's not the differentiation between sex,
Okay.
but what it differentiates is women are protected with estrogens for a period of time. However, when women get to a certain point with menopause and they lose estrogen levels, their risk for cardiovascular disease skyrockets and then equals men. So early on, women are protected. Later on in life, women are actually as bad, if not worse than men. Actually, in some instances, women have more disease because they have smaller caliber, smaller sized coronary arteries, which means plaque buildup is more significant.
Wow. I had no idea. I've learned a lot right there. Thank you so much for explaining that.
Oh, you're welcome.
Well, I think that this wraps up this podcast today. Thank you so much, Dr. Rondino, for taking the time to sit down with us. This was extremely informative, and I really appreciate your time.
Well, thanks for the invite.
So I hope everyone enjoyed this episode. Until next time, take care.